Thank you so much for that lovely introduction. And thank you, Dora, for the invitation to be here. The title of my talk is actually a little different than what's on the program. The title that is in the program is the talk that I was going to give 2 years ago. So the positive reappraisal of not having that conference 2 years ago is that now I have more stuff to talk about. So let's get started. So I'm a researcher, and I really want to give you a researcher's perspective on positive psychological interventions, or positive emotion interventions, or positive emotion regulation interventions, or stress reduction interventions. I titled this same program different things depending on the audience. For this group, I will call them positive psychological interventions. And as many of you know, these are interventions that are aimed specifically at improving positive emotional well-being. So as compared to interventions that may happen to increase positive emotional well-being, but are really targeted at reducing the negatives. So PPIs really focus on increasing positive emotion and other aspects of positive emotional well-being, and often consist of things such as gratitude practice, savoring acts of kindness, and positive reappraisal. We have a lot of evidence now, a lot of studies that have demonstrated effects of positive psychological interventions on various aspects of positive well-being, as well as depression and anxiety. So down there in the bottom left are the effect sizes from this. I believe this is the most recent meta-analysis of positive psychological well-being, but I'm probably wrong because it came out in 2020, and they just keep coming in. But this one was extremely thorough by Carr and colleagues, and demonstrated that across a number of different types of PPIs, there are, small to medium, but very respectable effects on well-being, strength, quality of life, also on decreasing depression, anxiety, and stress. There we go. So my team and I have been doing this work for almost 20 years now. And this is sort of the theoretical model that we've been following. So the idea is that a PPI, the positive psychological intervention, affects most proximately positive emotion. So this is the target for all of our interventions. I was recently chastised by a journal editor to talk about positive emotion as one of the mediators of the effects of PPIs. So I will say it is not the only mediator. There are other things that PPIs influence that then have downstream effects. But for our program of research, we really focus on positive emotion specifically. And we hypothesize that positive emotion, once you increase positive emotion, there are a number of things that flow from that. Things like positive emotions give you a timeout from ongoing stress. It improves your coping strategies. Positive emotion broadens your attention and your behavioral action tendencies, as we know from the broaden and build model, Barb Fredrickson's model. Positive emotion also, or these interventions, reduce your reactivity to daily stressors. So backing up just a little bit, our whole program is really couched in the idea of stress and coping model, that life is stressful. We study this intervention in groups experiencing a variety of different types of stress, but also daily life stress, because as we know, life is hard, right? So these interventions also help you maintain your emotional well-being throughout the sort of daily stressful events, both major and minor. And these interventions also tend to strengthen social relationships, which then, of course, have a feedback relationship. So taken all together, those proximal effects reduce your experience of stress overall. It improves your there are physical pathways that are helped when you increase your positive emotion. And then there are also behavioral pathways so that people with more positive emotion engage in better health behaviors. And thus, then, this all results in better psychological health overall, as well as physical health. So Over the years, we've conducted a number of studies. As some of you may know, we name our studies using plant and flower and other botanical acronyms. So this is just a depiction of some of our studies: cedars, lilac, larkspur, dahlia, orchid. There's a laurel in the corner. There's a couple others that aren't plant-based, but those are my mentees, have taken the program and gone other directions. So they get to start their own line of acronyms. So what I want to talk about today is sort of the progression of different types of studies looking at this same multi-component positive psychological intervention. So starting with efficacy, moving to effectiveness and implementation. And I should say, before you get to efficacy, there are things like proof of concept and feasibility and pilot studies where you're not actually testing whether your intervention has some impact on your outcome, but also whether you can just pull it off. Will the people do it? Is it feasible? So, but starting with efficacy, an efficacy trial is really testing the impact of an intervention under the ideal circumstances. So this is when you do a very tightly controlled, randomized controlled trials where you're very selective about the people who are eligible for the study. You exclude people with things that you think might mess with your effect, in a best scientifically rigorous way. But the efficacy trials are really sort of testing the core of your hypothesis in a very cleanly, tightly controlled study. Then we have effectiveness trials that really are more under real world conditions. So maybe not as tightly controlled. Maybe you let in a wider array of participants into the study to see if you can work across different individuals. And then you can move into implementation studies where you're really looking at the uptake of an intervention that's been demonstrated to be effective into sort of routine practice. So whether it's clinical practice, whether it's a school-based implementation, it's sort of implementation of that practice in the real world. So it was about a year or so ago, I was in a workshop where we were talking about positive psychological interventions. And Stephen Schuler, who many of you know, presented this sort of subway model that he had adapted from Lanefall, Curran, and Beatus, looking at sort of the relationship and the progression from efficacy to implementation. So the idea is that, I do have a laser. Yeah, there we go. You identify the practice of interest. So in this case, we're talking about positive psychological interventions. If you have some evidence of efficacy, you can move on to effectiveness. So if you've done the tightly controlled study to show that you're doing what you think you're doing with the intervention. If you don't have efficacy yet, you do the efficacy research, the randomized controlled trial, and try to get that evidence. If you're not finding it, I wouldn't give up just yet. You may need to do more efficacy research staying at this stage, but also design with an eye toward implementation. So you don't want to test an intervention that it can never get out of the lab, that you can never take out into the real world. So when you're designing your efficacy trials, try to keep in mind where you ultimately would like to have this program implemented. So then once you've got some evidence of efficacy, you can move on to effectiveness, where you test it more in the real world, and I'll give some examples of this. And if you're getting some evidence that your intervention is effective, you move into implementation, and there are different types of implementation studies, and I'll talk about these just a little bit. Okay, so the first trial that I did, the first efficacy trial that I did of this multi-component positive psychological intervention was the IRIS study, and IRIS stands for Intervention for Those Recently Informed of Their Seropositive Status. And this, like I said, it's multi-component. So we brought together a number of skills or behaviors that we had seen from positive psychotherapy, from coping research, from some of our own work. We brought together these 8 skills to test in people who are newly diagnosed with HIV. So noticing positive events, savoring, gratitude, mindful awareness, so very much focused on the awareness and non-judgment pieces of mindfulness and not the full array. Positive reappraisal, noticing personal strengths, setting attainable goals, and acts of kindness. So we recruited 159 people, like I said, who were newly diagnosed with HIV. This was within about 12 weeks of getting the news that they had HIV, so pretty much an acute, stressful event. And they were randomized into 2 conditions. One, to learn the 8 skills that I just showed you in person, individually delivered by a trained facilitator. So they came into our lab, a lab nearby, and learned the skills 1, 2, sometimes 3 a week over the course of 5 weeks from a trained facilitator. The control group also came in once a week for 5 weeks for about an hour, so the same amount of time, with the same facilitators, but they didn't learn skills. They got to talk about themselves, which, as many as you know, is a potent intervention in and of itself, but they weren't learning these positive skills in particular. We were doing interviews, basically. So they came into the study, 159. They were randomized to the intervention or to the control condition. They went through the 5 weekly sessions, and then they completed post-assessments at 5 months post-diagnosis, 10 months post-diagnosis, and 15 months post-diagnosis. So over the sort of, you could think of it as the psychological recovery period after getting the news that they were HIV positive. This graph is a way I came up with to look at all of the outcomes. So if you're like me, when you get a chance and you get the funding to do one of these efficacy trials, and like I said, this is the first one we did, I measured everything I thought could possibly be impacted by the intervention. And some were and some weren't, but it just felt like with the time of the participants, with the money from the National Institute of Health, it was important for us to really measure everything that we possibly could without overburdening our participants to see where the effects might be of this intervention. So what you have here, this is positive emotion over the past day, and these are effect sizes for the difference between the 2 groups, between the intervention and control, in change from baseline to the 5 months to 10 months and 15 months. So those are the 3 bars, 5 months, 10 months, 5 months, 10 months, and 15 months. So for positive emotion past day, there isn't much of a difference between the intervention and control in change from baseline. So slightly more of an increase in the intervention group compared to the control. It was not statistically significant. The effects seem to grow over time. When you look just within time point, by the time we got to 15 months post-diagnosis, this was a statistically significant difference. For negative emotion over the past day, we did not get an effect that was statistically significant. The CESD is depressive mood, no effect there. The impact of event scale, which is intrusive and avoidant thoughts, so these are sort of PTSD type thoughts about having HIV. This was a statistically significant difference, such that the intervention group had fewer intrusive and avoidant thoughts compared to the control. Antidepressant use, this was unexpected, but since I measured so many things, I found it. I'm not recommending that, by the way, that's fishing. So this was a single item, are you taking an antidepressant right now? And at baseline, both groups, it was something like 17% of both the intervention and the control condition were taking antidepressants. But by 15 months post, the intervention group, it was still about 17%. The control group was up to about 35% reporting being on antidepressants. It could be that the intervention group was using the skills that we had taught them and thus did not need to go on antidepressants. But of course, we can't conclude that just based on these differences. It's a possibility, so it's a hypothesis. And then for anxiety, a similar, although not quite as clean, effect. So for physical health and health behavior, this was the most exciting finding to me in this group. So in HIV, the goal is to have a non-detectable viral load. And at the time we were doing this, under 200 was non-detectable. So this is the percent of individuals in each group who had an undetectable viral load. So there's a big difference between the intervention and control, as you see. So 0.4 over 0.4 effect size in the difference in change from baseline to 5 months, or 10 months and 15 months. So what this meant was that by 15 months post-diagnosis, 76% of the control group had a suppressed viral load, had undetectable viral load, which was what you saw. This study was done in San Francisco. In the San Francisco Bay Area, 76% suppressed viral load was what you saw in people that far past diagnosis, people not in my study. The intervention group, 91% had suppressed viral load, which from a public health perspective is huge. Just learning these positive psychological skills had that kind of effect on viral load. Sadly, it was not statistically significant, so the journal editors made me take it out of the abstract. But I talk about this finding every chance I get because I think it's huge. And one of the things we have with positive psychological interventions in general, we've got lots of evidence that they impact psychological well-being, not as much that they impact physical health. And this is one of the cases where they do seem to be having an impact on physical health. So there was somewhat of an effect on doses of missed antiretrovirals, such that the intervention group was less likely to miss taking their medication. But again, not quite statistically significant. So, that was a really great start and gave us some confidence that, certainly this intervention was feasible and it was acceptable. We could pull it off in a group that was highly stressed at a highly difficult time in their lives. And we then branched out from there, testing the study in other groups as well, dementia caregivers, women with breast cancer, people with type 2 diabetes, all very much at the feasibility sort of efficacy stage. And then COVID hit, and I'm in the Department of Medical Social Sciences at Northwestern in Chicago. And at the start of COVID, when we all went virtual, we were having weekly, departmental meetings about coping with COVID. And we're a bunch of psychologists, so we talk like this. And some of my colleagues asked whether we could make our program available to the people in the department to learn these skills. And we were, at that time, and we still are, running the study in dementia caregivers and had moved the intervention to be an online self-guided version. So it wasn't a huge lift for us to say, sure, we can make a copy of that and bring it over and make it available to the department, just, because it might be helpful. And then because I can't not collect data on this intervention, we made another copy that we had approved by our Human Subjects Board for sort of not the friends and family, but for other people who were starting to approach us and say, do you have something that people can use for coping with COVID? And this is now in the effectiveness realm. I didn't have a control group. There was a problem out there. We were getting requests for the program. We thought, okay, let's see if it has an effect in this much less rigorously controlled trial. PARC stands for Positive Affect Regulation Skills. So it's not my best acronym, but now I'm going down this road and I'm just going to stick with it. Okay, so the questions we were asking are, can a positive psychological intervention influence well-being in the context of the COVID pandemic? Does the intervention improve scores on these well-being outcomes? In this case, we really wanted to make the measures very brief, no burden at all, and we used the NIH Promise computer adaptive test, which I highly recommend. We measured positive affect, meaning and purpose, social isolation, anxiety, and depression. And on average, to do all of those, because they were computer adaptive, which means like each question you answer then determines the next question, and it gets you to a very precise score very quickly. Overall, on average, participants were spending less than 3 minutes doing all of these, which I kept having my data manager go back. I'm like, that can't be right. That can't be right. But she's like, yes, it is. I'm telling you, 3 minutes. So I recommend these measures as well. So we recruited, we recruited a few more. This is up through like last fall. And we do have a paper coming out that has all actually the program's still open if you want to do it. But this was when we had 547 people. Just some things to point out. This was only US based. That's what our human subjects board required. So no one outside the US. 73% female, 76% white, and extremely highly educated. So keep that in mind when you think about who do these programs work for. Well, these are the people who come to do the program, right? So that's really important. So just looking at pre-post change, again, no control group, we got significant reductions in anxiety. Oh, so again, the program, 5 weeks, self-guided, so they logged in each week to learn 1 or 2 skills, just takes a few minutes to learn the skills. And then there's the opportunity for practice on the website. Or, I mean, they can certainly practice on their own, but they have a way to practice on the website. There's a discussion board. There's some sort of badges that they can earn. I'm not convinced that people are really using those. Well, I know they're not using them to their full extent. But they do have this opportunity to really engage with the platform. So this is just pre-post, so we gave them about 8 weeks to get through the whole thing. So significant drops in anxiety, depression, social isolation, increases in positive affect, and a tiny increase in meaning and purpose that was not statistically significant, which is really saying something because we had a big sample. So really no change in meaning and purpose, which doesn't particularly surprise me since it was really targeting positive emotion and positive affect. So something you might be thinking, without a control group, could the observed changes in well-being just be due to the passage of time, right? So we've all been dealing with the pandemic now for 100 years. And maybe it's just, you come in, you sign up for a program like this because you're feeling particularly stressed about it. And then whether you do it or not, maybe things just get better, right? Certainly a possibility. So one thing we can do is compare the scores on people's baseline, and these are in the blue dots, to people who are completing their post-assessment, the orange dots, at the same time. So that sort of gets at this cohort effect, this potential cohort effect of everybody's getting better, which actually is not true. But if you compare the blue dots, and you can see the blue line that has their average there, to the orange dots, depression is definitely lower in the people who've had the opportunity to do the program compared to those who are just entering the program. So that's depression, positive affect, also significantly different between people who've just completed the program and people who are just coming in. And the same was true for anxiety, but again, not for meaning and purpose. And also, did I show you positive affect? Yes. So some really important caveats on this study. Of those who completed the baseline, only 42% completed a follow-up assessment. So what I'm showing you is a very select sample who improved, right? They're the people who stuck around long enough to do the post. 30% of those who signed up, completed a baseline, we gave them the login information, never logged in. Among those who did log in, so a good number, 86% completed at least one skill, but only 14% made it all the way through. And we do have a paper coming out by Liz Addington, my colleague, is coming out in Affective Science, where we really talk about this. We talk a little bit about the efficacy findings or the effectiveness for what it is. Like, the interventions worked for the people who did it, right? But there's this issue of the people who didn't do it, who thought they wanted to do it but didn't. And what do we do about that? So we spend a lot of time in the paper sort of comparing the people who logged in versus those who didn't, the people we call super users to those who weren't super users. So there's more information on that in that paper. Okay, so back to our model. Then moving on to more implementation. So, I've shown you a little bit of efficacy, and I have a boatload of studies in this area. So I'm pretty confident that we've got some effect going on with this intervention across different samples. Effectiveness, yes, for the people who do it. So, if we can figure out a way to deliver this program so that people will engage with it, I think we can help them. And then moving into these implementation trials where we're sort of moving them into the real world, I've started going in this direction with some more recent studies. And these are the ones you wouldn't have heard about 2 years ago, so yay. So ORCID was a study based on the IRIS study. So this was, I tried for years after having the results from the IRIS project in people newly diagnosed with HIV, to have this study funded to do it online in a self-guided format. And I literally submitted some form of this grant 6 times to the National Institute of Health. So persistence is key. And it wasn't funded. It wasn't funded after 5 rounds, trying different iterations of it. And then I was contacted by a group in Chicago, the AIDS Foundation of Chicago, who they oversee all the medical case managers in Ryan White clinics. And Ryan White clinics are sort of these federally funded HIV treatment centers. So there are 16 of these clinics in Chicago with medical case managers. And the AIDS Foundation had done what their goal was to implement a behavioral health screener that was standardized across all of the clinics. So they really wanted to measure depression and anxiety and substance use in every client at those sites, so they could evaluate how their program was, because they didn't know, and they had different things going at different clinics. So they, as the people who supervise all these medical case managers, they really wanted to do this behavioral health screener across all the clinics. And they had run a pilot, and one of the things they learned from the pilot test was that the medical case managers were reluctant to do this screener because there was such a backlog in behavioral health treatments that they didn't want to find out that someone was depressed and then say, I'm sorry, you're going to have to wait 6 months to get into a group or to see a therapist. So there was a call that came out from our National Institute of Health to look at implementation of behavioral health studies in Ryan White clinics. So it sort of had our name all over it. And AIDS Foundation reached out to us and they said, we're looking for an intervention that could be delivered sort of right away to folks who have maybe elevated depression or anxiety in our clinics, and these are all people living with HIV. And I was like, that's great, because I'm looking for a place to implement my intervention for people with depression or who are coping with stress of HIV. So we partnered with AIDS Foundation and wrote the grant. And what we ended up proposing is what's called a hybrid type 2 trial. So it's a hybrid trial where you're looking at both effectiveness and implementation equally. So we are interested in whether the intervention reduces its depression in this case, so reduces depression via increased positive emotion, in my mind, whether it reduces depression. So we really are looking at that effectiveness piece, but we are also equally looking at implementation, like how are we implementing it alongside this behavioral health screener? Who's giving the screener? Once they find someone who screens high on depression, are they referring them to our program as well as other programs? It's not like this is the only one. This is like the immediate program that they can get into right now, and then they can get on the wait list for other things if things aren't available. So we have this equal focus on implementation and effectiveness to respond to the concerns that they had from their pilot study, and also to improve the long-term sustainability. So the idea is that they will be able to sustain this, their behavioral health screener longer term past the life of the grant, and maybe they can also continue using this intervention if we're showing that it's effective. ORCID stands for Optimizing Resilience and Coping with HIV Through Internet Delivery. And these are the skills. The difference from ORCID is that we've swapped out acts of kindness and really focused more on self-compassion. We haven't taken acts of kindness out completely, but it's now sort of kindness for self and others with much more of a emphasis on self-compassion, which we felt was important. We were fortunate with this grant to have an entire year of pre-implementation work. So it's not like most studies where you sort of have to jump right in and start the trial within 3 months and get it going. We really had lots of time to do surveys with the case managers and their supervisors within each of the 16 clinic sites. So we went in, we talked about the behavioral health screener, described what that is. We talked about ORCID, described what that was, and really talked through the sort of the facilitators, like why might this be a good thing, and how might this be difficult to implement at your site. That was done in a survey, and then we followed up with more in-depth interviews to get more detail on that. And then in the final phase, we sort of put together our implementation plan to have these medical case managers do a screening for all their clients as they came in. And then for those who had elevated depression, they would then be referred to ORCID. We are conducting what's called a stepped wedge randomized controlled trial. So this is still the effectiveness piece of this. In the 16 clinics, we're randomized into 3 groups. We are in our first step where we are just looking at this implementation in 5 of the clinics. So they're implementing the screener and referral to ORCID, and then we are just about to do our evaluation of that. We've been doing the evaluation of the implementation all along, which is how we know it's not going well. But we're doing the more official implementation before we then launch into the second set of clinics, where we will then again evaluate the implementation. And then finally, with the third step, we will be doing evaluation of the effectiveness, which is in people who come into ORCID, we'll look at their pre-post changes and see if they're improving on depression and other outcomes. We will also look at the clinic level to see if clinics that have implemented this program have better engagement in care, if they have a lower average viral load. And I'm smiling because that's a really high bar. So we'll see. It is not our primary outcome, but we will be able to look at the clinics where we've launched the implementation versus those that have not yet launched and look for these clinic level differences. We did, over the course of some preliminary work that we were doing in people living with HIV, and also that first year, we did some adaptations to the online program. We adapted the literacy level. Every time I launch another study of the self-guided intervention, I and other members of my team go through the intervention, right, as a participant, just to see what it looks like with this new iteration. And I am embarrassed to say that I never clued into how high the literacy level was. Some of the feedback we got was, well, that's a lot of words. There's so many words on the page, and it's extremely wordy, right, like my slides. So we aimed to get it like a 6th grade reading level in literacy for this. We also made it optimized for a mobile phone. So originally the program was optimized for tablets that were about this size. It is adaptable, so it can be used on a laptop, on a desktop, on your phone. It just didn't look great on the phone, and we knew that most of our participants in this study would be doing it on the phone. So we optimized it so it would look great on the phone. We also added an audio feature for accessibility. So if people don't want to read through all those words on the page, they can just click a button and it will be read to them. So we're learning a lot. Like I said, we're just finishing up our first step of the 3 steps of the step wedge trial. Implementation is really hard. It's really challenging. It's clear that even though we're doing this in 16 Ryan White behavioral health clinics with medical case managers, no one size is going to fit all for this. There's differential adoption. There's a huge amount of turnover in the case managers and other staff. So even though we trained them initially, we have to keep training new staff, and then people leave, and sometimes they don't have any case managers at all. So that's been a real struggle. We did have our largest clinic, and luckily they've been randomized to the very last step, so we've got some time to figure it out. But our largest clinic that has a very active behavioral health program of their own, they saw what we had to say, and they're like, we're not really interested in the research. And we're like, well, but you don't have to do anything. Like, it's your case managers who are doing the referral. They click a button in their electronic health record. It's not hard. They have to do the screener, and then it's just to click it, and they're like, no. So I think they'll come around, but we've got a little bit of time to figure that out. So we had planned, just sort of optimistically, as one does when you're writing a grant, that we would recruit 100 people into ORCID with each of the steps. So at this point, we should be at 100. We're at 3 people. So we are spending a lot of our time looking at sort of the cascade from the time someone comes to the clinic. If they have an appointment, they come into the clinic, we know they're eligible for the screener. Did they get offered the screener? Did they take the screener? Did they have a high level of depression? Did they then get referred to ORCID? So there are many places where that could fall off. So we're really looking closely at that sort of cascade and figuring that out. And training and retraining and showing up again. And what else can we give you? Can we, like we They wanted little palm cards with those QR codes on them so that people could just do that and then go to the eligibility screener. So we've tried to make it as easy as possible to get clients to ORCID if they are eligible. And why I'm not freaking out at slow recruitment? It's because it's an implementation trial. So the beauty of hybrid implementation effectiveness, I already know this intervention works. We've published it, we've seen it across multiple studies. The intervention works. Now our challenges are in implementation, and that's what we're gonna figure out. So that's my appraisal, and I'm gonna stick with it. Okay, so one final implementation, more purely implementation program is the Forest study called Fostering Optimal Regulation of Emotion to Prevent Secondary Trauma. I like this one. In this case, these are basically the same skills as an ORCID. We've added more on emotional awareness up front, and I'll maybe talk about that in a minute. But otherwise, the skills are basically the same. And this came about in August of 2019. The American Psychological Association conference was in Chicago. So I was there, and it just so happens that one of my best friends from high school and my roommate is the chief communications officer for the American Psychological Association, which is huge. There's tens of thousands of members, and several thousand come to the conference. So she's in charge of the entire conference. And I was sitting next to her in one of the main stage events, which had 3,000 people at it. And they were talking about gun violence. You may have heard the US has a big gun violence problem. One of the speakers was Eddie Bocanegra, who was the executive director of a program called Ready Chicago, which provides those, they go out and they find men who are at highest risk of being involved in gun violence, so either as perpetrators or victims. They invite them to come into the program, then they get training in cognitive behavioral skills, they get job training, they get transitional jobs, they get other sort of development training, so these sort of wraparound services. It's a 12 to 18 month program, and there's good evidence that this program is starting to work. So I heard Eddie talk. He himself has been involved in gun violence. He killed someone as a teenager and went to jail for it, and then came out, got his master's in social work, and has dedicated his life to doing this work. So really inspiring. And after the talk at the panel, and there were a couple psychologists on the panel who talked about, predictors of who's gonna pick up a gun, and it was normal psych stuff. And all the questions afterward were by psychologists who like to hear themselves talk and I really think we need to work on toxic masculinity, and I need to, and no, not a single question for Eddie. All for the psychologist. And I'm like, we gotta get out of our own heads and do something. This is ridiculous. So my friend turned to me and she's like, aren't you gonna ask a question? I'm like, not in this forum. And she said, why don't you come backstage and meet Eddie? So that's my connection right there. So I met him backstage and I was like a fan. I'm like, I'm a psychologist, I work in Chicago, how can I help? And his first thought was, well, you're a psychologist, maybe you can help with the cognitive behavioral skills, the fidelity to that. We could use some oversight. And I was like, well, I'm not that kind of psychologist, sorry. I'm a social psychologist, right? And then he said, what do you do? And I said, well, I have this program of positive emotion skills that helps people cope with stress. And he didn't go, oh, that's ridiculous. He said, can you help my staff? So he immediately went to the frontline workers who themselves live in some of these communities that are really highly impacted by violence. They may have been involved in the justice system themselves. They are working with clients every day. They are very close to violence and trauma, a lot of secondary trauma, high rates of burnout and turnover. He's like, could your program help my staff? I was like, I don't know, but let's try it. So my team and I, and this is Liz Addington and Elaine Chung, they have 3 sites in Chicago that they work out of, Ready Chicago does. So we went and we presented the program to all the workers. They've got outreach workers and coaches and managers and staff and all of the folks who work within the program. And we presented to each of those sites and we gave sort of a brief overview of the skills. We had them practice some of them. And then we said, who is interested in learning more? So from each of those sites, we recruited about 5 people from each site across job classifications. And taught them the skills. So we called this the Positive Emotion Ambassadors Program, which you note peas are also a plant. And we really worked in close partnership with Ready Chicago to develop this training program. And this was done in the fall of 2020. So it was all on Zoom, and where we went in weekly and we taught one or two of the skills. And then we had extra time added on. It wasn't just our usual sort of telling things at the people who are learning the skills. We had time to sort of discuss the skills then and say, would this skill work in your workplace? Would this work for you? What are things that you're already doing? Because they already have a lot of sort of activities set up at the different sites for sort of maintaining well-being or sort of helping with well-being or coping with stress. Where might these skills fit in at your site? So we had time to talk about that as well. Here's how we group the skills. And then we had a sixth session, which we sort of ran as a focus group, talking more about the skills and how they might work. And then we also did some more in-depth interviews to follow up even more, to get more feedback without the facilitators in the room, because they may not be as forthcoming if I'm standing there and I'm like, I just taught you all these great skills. What do you think of these great skills? We had a neutral interviewer ask them more. They still think they're great. So, for example, some of the feedback we got. One of the positive emotion ambassadors said, I think for staff, it's absolutely necessary and important because you can have burnout. You're dealing with not just the emotions of yourself, but of an entire group of other people that have a lot of things going on with them. And you have to tackle that on a consistent basis. Ps is necessary. I wish it had been longer. I wish it had been 12 weeks and not 6 weeks. It could have been longer. And then another one of our Ps had this quote about the raincoat, which we liked so much that we put it on the back of the journals that we gave them as a thank you gift. And this is Tristan McDowell who said this. The use of positive emotions, it feels almost like going outside with a raincoat. If you go out with a sweater, you get rained on and your shirt gets heavy. You have to carry that burden. The raincoat allows that stuff to wash off of you. Oftentimes at Ready, we're standing in the rain all the time. I feel like we're often the people who need to remember why we're here and reminding us and giving us tools to not let these things weigh us down. So some of the things that we learned from that program, from that sort of preliminary program, they really wanted more science and information on trauma to make it more trauma informed. They wanted more cultural tailing, more pictures that looked like them and their participants. They wanted some refining of the skills, more detail on emotional literacy, which could be an entire program in and of itself, as you know. Positive reappraisal, strength, self-compassion. They wanted some change, or they suggested some changes with how it was delivered. They really felt that it was helpful to learn it in a group and have that interactive piece, but they also wanted regular refreshers. So like, what happens now? So we've learned it in a group, we've got these skills, now what? They also wanted to talk about other ways to practice the skills. So we have sort of a set that we talk about, put it in your diary, put it on social media, different ways to practice these things. But they had other suggestions that they suggested we incorporate. A big thing that we haven't quite figured out yet is how do you use these skills in moments of crisis? And I think, Richie Davison talked about using these skills, the mindfulness skills, in the moment. And that's also what we need to figure out. When you're, working with a client who's getting violent in the moment, or you're, other sort of high crisis moments, is that the right time to be thinking about positive emotion? Maybe not, but it's something they really wanted to talk about. So again, patience and persistence is a virtue. A call came out from our National Institute of Health for grants on firearm injury and mortality prevention research, which is not something that would have caught my eye prior to doing this work. But we said this could be a perfect fit for what we want to do next, so we put in a grant where we aim to adapt, implement, and manualize the forest program and build capacity for Ready Chicago to sustainably enhance resilience, prevent burnout, and reduce turnover among frontline staff working to prevent firearm injury and mortality. So this is a phased grant. There's a lot of NIH US-based lingo here. But the first phase is 2 years, and it's exploratory, where we will do this sort of adaptation of the forest program and incorporate more of a trauma-informed perspective, which they've asked for, and identify other things that we need to adapt. And we're figuring out sort of the strategies. What are the implementation strategies? How do we take what we have and implement it and infuse it into the culture at Ready so that it is just what they do? It's not just another thing on their learning management system that they click off and then go about their day. And then we're also, in this first 2 years, designing the next thing. So then once we have what we want to implement, how do we evaluate it? How do we do the longitudinal study to see if it's effective? And then that second phase is 3 years long, and we'll actually do the thing that we've designed in the first 2 years. My whole team, we are working very closely with Ready at every step of the way. This would never work if it was just me going in there and being like, I have a positive emotion program, try it. So we're really going with we're taking their lead in how they think these skills might work. When we got funded, our senator in Illinois, the senior senator from Illinois, Dick Durbin, has been doing a lot of advocating in the US with our National Institute of Health and the Centers for Disease Control to free up money for gun violence prevention research. There's been sort of a squashing of funding for that research for a number of years, and Dick Durbin's been a strong advocate to get calls like the one that we got a grant for out there so that more of this research can be done. So this is Dick Durbin at Ready Chicago. So he saw the grant, reached out to Northwestern Communications and was like, can I talk to Dr. Moskovitz and have her be part of a press conference on this? So here we are at Ready Chicago. There's Eddie Bocanegra, and a researcher from the University of Chicago, which is actually evaluating the effect of the Ready program itself and looking at involvement in gun violence in the participants of the program. So we are just at the point where we are completing, we completed several focus groups with each of the job classifications to talk about how they see stress, how they see wellness, how they cope with stress, and to get information on programs that they've seen work at Ready and programs that haven't worked. So what are sort of the facilitators and barriers to pulling off a successful implementation of a program at the Ready Chicago site? So we're pulling that information together now. We're going to follow that up with some more in-depth interviews, and then we'll finalize the content and figure out how we're going to evaluate it. And then in year 2, we will be moving toward actually implementing the program, hopefully. So the second phase of this is not guaranteed. We have to meet all these milestones for year 1 and 2 to then have NIH release the funds for the subsequent 3 years, but we are optimistic. So sort of in conclusion, I think positive psychology is in a bit of a rut with our evaluation of positive psychological interventions. And what I mean by that is that anyone who has an idea for a PPI and a sample that they want to do it in, they go and they do a little pilot. And then the next guy goes out and says, I have an idea for a PPI, and I have a sample, and I'm going to do a little pilot there. And we don't tend to move beyond that. There are absolutely exceptions. Richie Davidson is a shining example of how to do this. But I urge you not to just do another, like move on, make it an effectiveness study, start thinking about, and I know a lot of the practitioners in the audience are much more likely to go to the implementation phase, and I applaud that. But I think we need to work together with the people who are looking at efficacy and effectiveness and then marry that with the implementation so that we're doing the best evidence-based programs out in the world. We have a joke on my team that I probably shouldn't let out here because people will be offended. And no one in this room will be offended. But every time we work with a new group, and this has happened in particular when we work with healthcare providers, like we did some work with surgeons and taught them this program, and they seemed to like it, and that was great. And then we were talking with a group that were anesthesiologists, and they were like, oh, we need something really, anesthesiology is really stressful, and these skills really need to be different for us. And they really don't. So, although I started my work in people living with HIV, as you saw, the skills themselves, those basic skills, don't change really. These are human things, and different skills work for different people, but, they don't have to be a completely new iteration of a completely different set of skills for every new group. So we started calling them special snowflakes because they thought they were so special that they needed something completely new, which is not true. On the other hand, if you have done sort of a feasibility trial or a pilot trial, and maybe the effects weren't as strong as you hoped, don't throw it out. Like, figure out why it didn't work. And if you can, again, this is all with the grace of good funding to be able to move along these places, but like, stick with it. I've seen folks who've done like really excellent trials in PPIs that have not quite turned out the way they thought, and they're like, it doesn't work. Like, no, it does, it works. You just need to figure out how to present it and how to help people find the skills that work for them. So sort of both sides of that. Don't just do another efficacy over and over and over again, pilot trial. Also, don't get discouraged if your pilot trial doesn't turn out. So then once you have a PPI, and we have many that are demonstrated to be effective, then start moving toward implementation in clinical practice, in the workplace, in schools. This is not easy, but it's where we need to go if we want to have an actual impact on people's lives with the things that are stressful for them. Also, don't rush to the next stage before the data indicate that we should. So we have a version of this intervention in people with chronic musculoskeletal pain. And it was clinic-based, so we recruited through integrative medicine clinics. We recruited 66 people, more than 60. Showed good effects on positive affect, depression, some signal on pain, which is enough for me to move forward. But we had really poor engagement. So by the time they got to the last, that 8th skill, it was like, as this was online again, there was like half of them even looked at the last skill. And our sample was very white and very female. So I have no idea how this intervention works in people who are Black or Latinx, who are male. So the grant that I just put in is to really look deeply into, so we're doing focus groups in Black people with chronic pain, Latinx people with chronic pain, and actually non-urban people, so from people from rural and suburban areas, to find out about what they think of the skills, how we might tailor them to work for them, where they want to receive these skills, how do we reach them, what will make the most sense for them. So that's, hopefully we'll see if that grant gets funded. Not a linear process. This is clear from what I've been doing. In reality, we have multiple projects at multiple stages, and again, this is the grace of having an excellent team and sustained funding to do this kind of work. So don't be discouraged if it's not looking linear to you at this point. And then just a plug for the next World Congress, which is going to be in Vancouver, July 20th to 23rd. I hope to see you all there. We should be opening up registration and submissions to that very soon. Okay. Thank you.